Hello everyone, let's try to solve this question together. So a preterm infant who is monitored in the NICU, she's receiving total parental nutrition and dextrose of 5%, amino acid 3.5 gram per kg. No lipids because the triglyceride level yesterday was 410 milligram per deciliter, so the lipids are on hold. The calculated glucose infusion rate is 5.2 milligram per kg per minute. So based on the lab, the best action is to pause the slide, take a look. What do you guys think? Okay, the correct choice here is starting intravenous insulin. So the reason, let's walk through the reasons. So why A is not right? Because if you decrease the rate, what will happen? Your amino acid also goes down and you don't want to compromise on that. So that's why decreasing the rate is not a good option. What about the second one, decreasing the GIR? We need a minimum GIR to prevent protein catabolism. The only question is, with hyperglycemia and GIR, how can we just adjust that? So I think the best strategy would be to leave the GIR around 5 and tolerate, a glucose a little higher, plus use insulin to make sure that the glucose comes down. So that's probably a solution, but I don't have any evidence for that. And checking for glycosuria is not a routine thing because once the glucose goes above 180, the neonate will spill some glucose anyway. So that will not change the management plan. So that is probably easy to eliminate. So things to remember, this is this small box. If you guys can remember these things, that the serum or plasma glucose is 10 to 15% higher than the whole blood glucose because the red blood cells has more protein and the plasma has more dissolved glucose. So that's the reason. And this is the reason for keeping the GIR within the range because, you don't want more fat formation or you don't want more protein catabolism. But again, at this juncture, the question still remains that should we go with the serum glucose or should we go with the GIR when we are managing cases of hyperglycemia? Because there will be a point where your GIR is barely minimum to 5 and you still have hyperglycemia. So basing on the evidence which I'm going to show you in the next slide, the strategy should be to keep your GIR around 4.5 to 5 and not go below that. So this is one reference where they describe detailed management of hyperglycemia, and this article is good too because although it's for hypoglycemia, but it discusses all the mechanism involved in preterm babies with glucose metabolism. And again, the reason, we said, so if you have time, just pull this article. This is nice. It describes, the reasons. And again, remember, there will be variation. In Australia, they did a study and they found that there is a lot of variation in management of neonatal hyperglycemia. So if in your practice, you see, the practitioners differ in managing hyperglycemia, that's not unusual. There is many way you can skin the cat, but as long as the concepts are clear and we know that we don't want hyperglycemia to be prolonged, and at the other end we don't want our GIR to be as low as causing protein catabolism. At the other end, we have to remember that the osmolar load. We don't want to. We have to look at the serum osmolality as well. We don't want to use hypotonic solution because that will be detrimental to the babies. I hope this small presentation helps in better understanding of management of hyperglycemia in especially preterm babies. So please do comment, and if you have any other references about management, which one is better to follow, either GIR or hyperglycemia, please do comment and let us know. Thank you so much. Have a wonderful day. Bye.